Information gained from viewing the following program is not a substitute for regular exams by your physician and does not constitute a doctor-patient relationship. All information gained should be discussed and confirmed by your physician.
Hello, welcome to Healthy, Wealthy, and Wise. We're glad you joined us today. I'm Ed Krick, your host, and my wife Beverly Krick, our co-host. Today we're so happy to welcome Dr. Mickey Ask with us. He's a faculty member at Loma Linda University for the last 25 years. He's in addiction medicine and at the VA hospital in Loma Linda, and has been on the internal medicine and preventive medicine faculty here teaching and taking care of patients at the same time. A great addition to our faculty. We appreciate your service, Mickey. Today we want to talk about a problem that comes to many of our homes related to addictions that can come from medication that has either been prescribed or been taken over the counter. We've talked quite a bit in other programs about alcohol, and we're not going to leave that out of our discussion today, but we want to find out a little bit more about some of these things that can come up almost surreptitiously, if you will, or subtly, and hit us kind of in the face, and all of a sudden we realize, well, I've been using a medicine that now I can't get along without it. How do we identify some of those, and what can we do to help prevent some of that, Dr. Ask?
Well, again, the reward pathway of the brain is not very selective, and so it'll take anything that affects it. So the two main classes of medications are the pain medications, so we refer to them as narcotics, which isn't a precise term, but or the opiates, the opiate class. So an opiate is an opiate is an opiate. It could be codeine, which a lot of people use. Vicodin is the one that's prescribed a lot now. Stronger and long-acting ones like methadone or oxycodone. Higher dose oxycodone is OxyContin.
That's actually morphine, I think, isn't it?
Well, it's different. Morphine's another. There's morphine sulfate.
I see. And
fentanyl, so the patches, or they even have fentanyl lollipops now that can be used. So there's a variety of ways of delivery, a variety of delivery systems and forms of this. The other broad category are the tranquilizers, or the chemical name is benzodiazepines, but anything that would relax you or help you sleep, and anti-anxiety agents. So things like the most common ones now are Xanax, Ativan to help relax you. Things to help you sleep would be things like Restoril or Temazepam, Dalmane. Of course, the classic ones, Valium, Librium. So anything in those categories then affects the same part of the brain as alcohol, and then there's crossovers to the same part of the brain that's affected by heroin and cocaine and speed. So these systems all tie together and have an overlap.
It's interesting that all of those that you mentioned have the same kind of final common pathway, if you will, to make the brain relaxed or be able to sleep, to control pain. Tell me a little bit about the other side of this. Would not be a pill, but how about the natural endorphins and other brain chemicals, hormones, some of them are, that help a person feel better, and the stimulation that you can get, like maybe you got this weekend from your big exercise program. Mm-hmm. He ran about almost 40 miles this weekend.
So, yeah, to me that's always the first question, is instead of seeking a pill, what are the natural systems that we can influence that will have a similar effect? Now the problem, of course, is when we don't feel well, we want to feel well quick. I mean, take an example of a cold. We've all had colds. We know they're only going to last less than a week, but we're dashing off and taking this or that potion or lotion or pill and hoping to try to get better quicker, rather than just realizing, okay, it's going to take a week. I don't have to do anything. Whatever I do is going to feel better. Let me just take a little break here.
That's the modern American mindset. I think of back to our great-grandparents maybe, or whatever, 100 years ago. They didn't have any of these things really. Maybe a little bit of brew to take care of it, but other than that, there wasn't anything they could buy, no corner store to go to. But we really got ourselves into this kind of instant gratification. You've got to have it done right now. Patients want a shot rather than to let something take its course, like you're saying. You know, your cold's going to take a week to get over with. If you take something for it, you won't get any better any faster. It'll be 7 days anyway.
Right.
So,
well, and you know, partly it's, I think, because a person isn't aware if it's serious or not. It is hard. It's hard enough for us as clinicians to tell sometimes. So that also drives a person to then seek medical care, and then we feel a need to, I want something done, and the doctor on the other side wants to do something, and so a lot of times the collusion is to take a prescription. So it gives us the illusion that we're helping and that the patient's being helped. So a lot of times it works well, and the arena, though, that it has a lot of potential for not doing well is in this area that has crossover with addiction.
well, I'll have to say that my patients are really trying to avoid these medicines a lot these days.
Yeah, I've heard people say, boy, I sure didn't like that doctor. He wouldn't give me a prescription. And then, of course, you have the other extreme. You have the patient who probably gets more prescriptions than they should.
And part of that is a learned skill. I had one patient that he was using everything, so streets and prescription, and that was his learned skill, is how to get these things from a doctor. So he was alcohol, every imaginable drug you can think of. So it took me several months. I finally got him off of everything, and he was off of them for several months, and he was doing well. So he came back on a routine visit, and I had the resident working with him and getting the information. I walk into the exam room, and the resident's in the act of writing him a prescription for a narcotic. So I turned to the patient, I said, what are you doing? And he gets all sheepish and realizes what he was doing, and yet that was the condition cue, was seeing the doctor, and he knew that he could get something out of him. So we had to talk about that and unwind that. And you know, the person that's dying from cancer and needs strong pain medicine, everybody's afraid to give it to him because, oh, we'll make them an addict, and here they are terminal, and yet a good drug addict can get whatever they want from whoever. Had another guy that had a broken humerus that had healed, but it was still a lump there, and he would go into the doctor and, doc, it's hurting, I mean, look, but don't give me very many pain pills because I don't want to get addicted. So the doctor would breathe a sigh of relief, give him 50 instead of 100, and he was seeing 5 different doctors.
Oh my. Well, I think your example of someone who is near death from cancer and nobody wants to give them pain pills, that really kind of gets to me, because our purpose as physicians is to try to relieve suffering, and any way we can do it besides some strong medication that could have some downside risks, we'd like to do that. But when you get a case of a person who is near death and they're just in agony from some incurable disease, why not give them the medication? Is there any downside to that?
Rightly done, no.
Except that some family member that wants the medicine, I suppose, could take off with it or steal it.
That's one source of medicines. So every time I'm writing a prescription for a pain medicine or a tranquilizer, then I'm mindful of my other drug addicts that are then using them, stealing them, or getting them, or whatever, buying them, or whatever. So we have to be mindful of, just like everything we do, is first do no harm.
How can you tell if someone is getting addicted to some of these medications that are really not tremendously harmful? They can be helpful in the short run, certainly. Do you have any guidelines as to telling whether or not you've crossed over this line into some more difficult to manage situation or long-term problem?
Well, you know, when I first started, I used to pass this stuff out like candy. So I had no clue as a you know, budding physician until I would get I was out in practice now, and I'd get these people back that had been put on these things in the hospital, and they were getting refills, and it was 3 years later. Didn't need them, but nobody had spent the time to educate them. So I'm much more mindful now before starting, because I've had to pick up the pieces of where other doctors have prescribed addictive substances. So first thing is, are we dealing with an acute situation or a chronic situation? So if I'm getting a person that has a chronic condition, then let's look first at all the other non-opiate, non-narcotic ways of dealing with this situation. Why are they anxious in the first place? Is there something that we can teach them and give them and be intentional and focused on that rather than just giving them a pill? Now, if they're so anxious that they can't even get themselves to the class, then that to me is something different. But before I even start that, I'm going to do a good drug history. If they've had a family history or a personal history, then maybe giving them a substance that has cross-addiction potential, maybe that's not in their best interest. And there have been lawsuits on both sides of this. Well, what kind of a doctor are you? You're not treating my pain seriously. You're withholding pain medicine from me. I could have a better quality of life. So you're not a good doctor. Or on the other side, what kind of a doctor are you? You gave me a potentially addictive substance, and you didn't even ask if I was an addict. And you didn't warn me that I could get addicted to these. So it's like anything we do, we have to be mindful of a ditch on both sides of the road. And we don't want to, in avoiding the ditch on one side, we don't want to go so far away from that we fall in the ditch on the other side. So it comes down to being honest with your physician, and the physician taking the time to get a good history, always exploring all the other things that can be done.
This may require occasionally doctor shopping. Well, I don't want to use that term really because I don't like the connotation.
Doctor, yeah.
But finding the right physician, that's not always an easy thing.
It's not, and it's hard enough for us to know which colleagues to refer to sometimes. But it's time well spent, and I always like to ask several people. You can call drug treatment programs and ask about the addiction doctors, so addiction psychiatrists, certified addiction internists or family practice physicians. So again, through American Society of Addiction Medicine, or usually there's state chapters, state organizations of, so like for California, there's the California Society of Addiction Medicine, and we actually have online all the doctors that are in the organization and who have been certified. Oh. So that would be the group that would be mindful of the proper and the improper use of medications and can provide some guidance. Just calling a treatment center, they will have physicians that work with them, and then that physician, if they don't feel qualified, would be mindful of who the best people to work with are. Pain clinics, even there, some pain clinics, all they do is, okay, well, here's a pain pill, in addition to, okay, well, let's give you an injection, which again can be appropriate. So some pain doctors don't like dealing with the addiction part, they just want to do a procedure. And others are very good at it. So you have to be a good consumer and ask a lot of questions. I think it's a fair question. How comfortable do you feel dealing with addiction issues? And for those that are in recovery and want to maintain their recovery, finding somebody that's sensitive. Sometimes a physician in recovery is actually the best person, because so now that assuming of course that they're doing well and have gotten treatment and working an active recovery program, they're the ones that are going to be the most aware and sensitive to the addiction potential of these medications.
Let me go back just a step. If I have a family member, say for instance, that I see that is getting too many prescriptions and maybe going around and maybe having 2 or 3 different doctors so that they can get what they think is their need of supply of medicines, morally or ethically, what steps should a family member take to try and intervene and stop that process of the too many prescriptions?
Well, I think as a concerned loved one, then that's our natural tendency, is to want to help that. And it would be the same thing as a person, a family member or friend of somebody who had an alcohol or street drug problem. I think the best place to start is to, instead of trying to tell them what they should do, is to start with expressing your concern. You know, as someone that cares about you, I'm wondering, I've noticed certain behavior. I've noticed that you seem to be kind of sleepy all the time, or more irritable than what I know you to be. You seem more stressed. You seem to be sick more, or I notice that you're taking a lot of medications. I'm just concerned about that. And then I would stop and then have a normal discussion. How satisfied are you with the way you're trying to approach it? Are you satisfied? Is it working? Okay, so then if they're not satisfied, then that gives me something to work with. So would you like it to be different? What things have you tried? Would it be helpful for you to know some other ways that could be of use? So I try to keep it conversational, and instead of me trying to give advice, necessarily, I try to elicit a concern from that person and then work with that.
That sounds like a very nice approach. I'd be interested in hearing from you some of these other modalities, sometimes they're called, these other approaches to taking care of the problem rather than a prescription. What are some of the things that can be helpful in that regard?
So sometimes pain clinics or physicians will formalize this into what we call a pain contract. So I don't necessarily formalize it, but I discuss the elements with the patient that I'm thinking about prescribing things to. Or I'll get a consult. The person is on a certain amount of narcotics that seem excessive to the primary doctor, and so they get a little nervous, and then they'll refer them to me. So I don't have any magic necessarily, but the elements that I'll discuss, first of all, is well, I'll ask the patient, in fact. I'll say, so how do you know if you're misusing these medications? Well, I'm not. Well, how would you know if it was becoming a problem? What would you look for? Well, if you can't come up with anything, I'd say, would that be helpful then to know what the warning signs are? So let's talk about that. So first of all, getting them only from one physician. So the physician has to know you and not going to different physicians. So, so if they're going to get something from me, I say, you have a right to have your pain lessened with everything that we can do to help, but we also have to practice good medicine. So if you're going to have me prescribe it, then it has to only come from me. Now you don't have to, that's fine if you want to go somewhere else, but if you're asking me for help, then this has to be the case. And that you take it only for the intended condition. So if I'm giving you a pain medicine, that doesn't mean that you take it to help you sleep, that if you're anxious or stressed, that you're taking it to relieve that, or if you're unhappy or angry. Okay, so here's the purpose. You only take it for that. Also, let's talk, instead of just talking about pain pills, let's talk about all the things that we can do for your pain. Do we really know what the pain is? Is it muscular? Is it nerves? Is it a bone issue? Is it a joint issue? What component is emotional? So I'm not saying, oh, it's all in your head, but I do bring up that there's an interplay between our physical system and our emotional system. And if you're tired and fatigued and upset, then you're not going to handle pain. In fact, how has that been for you? So I'll get them to talk about their own experiences, so it's not just me telling them something. We'll talk about that. And if you hurt too much, that affects your emotions. So we have to look at the whole picture. So excellent. What are you doing? Who do you talk to? What's your support? Do you have a higher power? I had one patient that was, he came back to me for his return visit, and he said, Dr. Askey said, thank you so much for saying what you did last time. It really helped. I said, oh, what was that? Tell me again. I'd like to use it again. So he said, well, you asked me if I had a higher power. And I remember the conversation because I was feeling overwhelmed with all of his litany of problems, and that's usually my cue to ask them about who do you turn to for support. And I said, who do you call your higher power? And he said, God. I says, so where's God with all these problems? Does he know? Does he know about these problems? Oh, yeah. And so that's about the extent of the conversation, and he was able to utilize that and turn things over and not feel as stressed. And then I didn't have to adjust his antidepressant. I didn't have to give him something, adjust his sleeping medicine, and increase his pain dose or add a pain medication because his back was hurting or his neck was hurting. So to me, as I've become more comfortable with that myself, it's actually made my practice more fun and exciting and given me more of a repertoire also. So there's other things too, but those are some of the elements I look at.
That's excellent, because the component of pain that has to do with emotions and support systems and family interactions, and whether the family feels like you have the pain, are you being honest about it? The family starts to think, is this person putting it on? Do they have other secondary gains almost? Or they're getting something else out of it? All of these emotional components are very hard for us to face. They're impossible to measure, I guess we'd have to say. So how do you bring those in then to make them a benefit in addressing that rather than a downside, so to speak, to take a look at the emotions? So I think you can ask what other potentials there are, for instance, for help from say, a pastor at church or a friend or someone else, and how does the family react with you? Are those things that can be beneficial probably?
I think, again, all of the above is whatever affects their well-being. So their physical health, are they exercising? Are they able to do, everybody's able to do something, so you have to look at what they're capable of doing. Do you have a meditation time? So a time when you're getting centered and a moment, some time to reflect and to feed your mind with something that's helpful. Sure. So some of my patients, it's always interesting to me how here's a hardcore heroin addict and he's talking about his morning meditation.
Wow.
It's fascinating.
It is.
So and they'll talk in terms of, yeah, I'm learning to turn things over and trust and realize that if I do my part in the footwork, that I don't have to worry about the rest. So I think having spiritual conversation around that is very helpful. Their social system, their health. I got all these patients that are overweight, that I have back pain. And you got to give me something, doc.
Surprise, surprise.
So, okay, I'm willing to give you something, but I don't want to be the only one working here.
Right.
I will only work as hard as you work on this. It's a cooperation. So I'm not here to fix you. I can only do so much. So I'm always working to try to enlist their cooperation and engage them in the process rather than turning to somebody else to fix it quick. So we'll have those. So yeah, it's harder, it takes a little bit more time, but you can do it, you don't have to do it all at once, but from a physician standpoint, you can piecemeal it.
From visit to visit, you could address those things.
Sure.
Well, we're not going to talk a lot about obesity today, but I'm glad you brought that up because it does impact so many different things: self-image, relationship with family, the back pain problem you were talking about,
joint pains.
Joint pain, so many other things that kind of tie in with that. So what do you do for those people? I mean, give us just a thumbnail sketch of what's helpful
for
obesity.
Overweight. Well, I'm always looking for that intersection of the physical and the emotional and the spiritual. So, some people have been physically or sexually abused, and so it makes them, if they start looking better, now they're going to be more attractive, and they don't want that. So it's serving a purpose. So here we go, we give them all these diet plans, and we give good calorie goals, and okay, go to Weight Watchers and Tops and so forth, and it's not about that at all. Okay, it's about some emotional issue. So that's why at Loma Linda we speak in terms of dealing with the whole person, because we're not just a collection of little boxes, it's all one big box of physical, spiritual, emotional, social, that we have to address. So I continue the conversation, I extend the conversation, and ask about those elements.
It's getting the whole picture and the whole man. That really is a marvelous concept, isn't it? How much can exercise help in this situation relative to perhaps the brain endorphins? And I know some people they feel like they can't exercise. What do you do with that group?
Well, there's degrees to everything. So I had, a long time ago when I was doing general internal medicine, I had somebody who was in a wheelchair. So we talked about getting into the pool. And they, one of the few ones that really followed your advice and took it to heart and got into a pool and started doing pool exercises, was able to get some more mobility to their joints and flexibility, and was coming in without a wheelchair. So it was really gratifying to see. So wherever you're at, even if you're bedridden, so then it would have to be passive exercises, and then so to the degree that they're capable of doing, trying to extend the range of what they can do, and being willing to ask for help. So the same principles applies with addiction. Getting with a group of people who have the same goal. There's Overeaters Anonymous, Weight Watchers. So the Overeaters Anonymous is more 12-step based, and Weight Watchers would be more focused on the calories and the pounds. Building exercise in, and for me, the only way I could do stuff is getting other people to do it with me. So when I don't feel like getting out of bed or doing that, I've made a commitment. So I say, oh, okay, I'll go, and then they get me over that hump. And then there's times when I get them over that hump.
It's the buddy system.
The motivation. It's most of my effort is in getting other people to do things with, and then I know that I'll do what I need to do.
Well,
I'm lazy that way.
Yes, well, I think all of us do so much better when we have other people to work with. And Bev likes her tennis. She can get out there on the tennis court and exercise with people, and she and I like to do our exercise together. But exercise is such a critical thing. I find in the patients as a rheumatologist, I have a lot of difficult times getting people to exercise. I've gotten to referring them to the Arthritis Foundation, which has pool programs. And for people who are having quite a bit of pain, getting in the water first. I'm glad you mentioned that, because that can be a huge benefit. I've had patients made quite a bit of improvement when they've done that.
Well, I'm always exploring people's motivation. I'll say, so how bad is it for you? Are you happy with where you're at? Would you like that to be different? Are you willing to do something to make that different for you? And if they're not, then sometimes it's a spiritual conversation, or maybe there's a psychiatric component or depression. So you can't jump in there and assume that you know what's going on with somebody. So you're always trying to focus on where that problem is, rather than just, it's easy for us just to give advice and not check in with the patients. So taking that little bit time extra to find out what their motivation and their desire is, and then start from there.
Well, that's a big challenge, isn't it? Because in the doctor's office, everything is so busy, you don't have the time that you'd like, you can't ask all the questions you'd like. And so it's nice that you point us to the idea that the whole person care is really what we need to do. And I think all of us as physicians need to take that to heart too.
And I think patients need that it's appropriate for them to pull on their doctors on this issue. And what are the other things I can do other than pain pills?
Yes, and don't be afraid, dear friends, to ask your physician to take care of some of these other things and be attentive to them.
And if they're not willing to answer questions, then I'd get another doctor.
That's a good idea. And we're so glad that you joined us today, because we want you to be healthy, wealthy, and wise. And our prayer for you is that today and every day you will adopt these principles and remember what we've talked about. Remember Proverbs 17:22, a merry heart doeth good like a medicine. This will help you be healthy, wealthy, and wise. You're watching LLBN TV. Look us up on the web, www.llbn.tv, and listen again next time to Healthy, Wealthy, and Wise.